Hi, wonderful students. This lecture talks about injectable medications. We're going to focus on medication administration. We covered pharmacokinetics and pharmacodynamics in week 3. This week, we will concentrate on enteral medication administration as well as injectable medication administration. Pharmacotherapeutics is a subtopic of pharmacology that considers the therapeutic uses and effects of medications. Understanding the desired outcome of administering a medication is as important as knowing exactly how that medication will work in the body, right? Very, very important. Understanding why the doctor's prescribing it, how it's going to have a positive impact, the side effects, adverse effects, and so forth, right? That's an important part of nursing responsibilities related to medication administration. Nurses are legally responsible for understanding the pharmacotherapeutics of all the drugs they administer. This knowledge is required to enable the nurse to assess the appropriateness of that medication, as well as provide appropriate and accurate patient education. Here are the learning objectives for this chapter. Please take a moment to review each one of these. If you can speak to these and apply these to your nursing practice, then you have accomplished your learning for this chapter. Okay, why do we give injectable meds? Think about some of the reasons we use the injectable route of medication administration, right? And we are going to talk about this more in depth in class, right? But we give injectable meds because we want the medication to have a quicker response in the body, right? Maybe it's because, the patient the medication needs to last longer. We want it to have a longer therapeutic response in the body. Remember, we talked about in class when we have oral meds, right? It has to go through the first pass effect, right? Getting metabolized by the liver. Well, guess what? We can avoid that by doing injectable meds, right? So not only are they absorbed more rapidly, right? But they avoid that first pass effect, right? So again, we can deliver, all kinds of injections, fluids, nutrients, all of that can be given directly into the body and bypass that first pass effect, right? Okay, so here are several different injections, right? Needles, we have vials. You can see that there are syringes and the one on the right hand side, the vial, it's a glass vial, right? And you have all of these in your nurse packs, and we are going to go through them, look at all of them in class, and break down all of these in class, right? So again, here is a monojet insulin safety syringe. You can see in the top figure 29 gauge, and the size of the needle, it's a 1/2 inch. So again, you have the gauge size and you have the length of the needle size, and on the top of where the needle is stored, housed, you'll have the breakdown again of the size of the needle itself. So the one on the bottom is 28 and a half gauge, and then we have 28 gauge and a 1/2 inch size needle, right? So again, these are just closer up pictures. You can see with the one in the middle, it is a 22 gauge 1 inch needle. It is a 3 milliliter syringe. Top one, 27 gauge 1/2 inch needle. Bottom syringe, you can see it is a 1 milliliter syringe, right? So you can see how with the smaller syringes, you can taper down even tighter on the dose, right? Here's the parts of the needle. Once again, you have your plunger, which pushes the meds inside the barrel into your patient, right? And then you have your barrel, which is what you draw the med up into. We have our needle hub, And then the needle is attached to the hub, right? You can see that the end of the needle is beveled, right? So when they shaped the needle, they beveled it. The lumen of the needle where the med comes out is beveled so that when it's inserted into the skin, it doesn't hurt as much, right? There's the shaft of the needle itself. And then again, once used on a patient, we do not recap needles ever. We're going to show you the swoop effect in class. That's the only way that you will want to put a recap on a needle. You never ever recap a needle. After use, you place the needles and syringes in puncture-resistant containers, again, without being recapped, because most needle stick injuries occur during recapping, and that's why you never will recap the rest of your career. Healthcare facilities are required to provide needles with needle guards to prevent accidental needle sticks, right? After the injection is given, you're going to push the needle guard into place using the one-handed technique that we're going to show you in class. That's been recommended by the manufacturers, again, to prevent needle stick injuries. Other needle and syringes combinations have a retractable needle that will retract into the housing unit. So it literally will lock back inside the syringe barrel itself. Pre-filled syringes are manufactured with retractable needle sheath covers. With these syringes, once the needle is contaminated, right, or used, the top slides forward and over the needle to prevent needle stick injuries. If recapping is absolutely unavoidable, again, you're only going to use the one-handed technique where you scoop it up, right? And then once it's covered by the guard or cover, then you can push it on, right? This technique is used in addition to protect healthcare workers from accidental transmission of infectious diseases off of that needle that we injected our patients' meds into, right? When administering parenteral injections, maintain surgical asepsis and use very strict sterile technique to avoid introducing organisms from that patient into your body, right? And the parts of the syringe and needle must always be kept sterile. So those parts must always be kept sterile, the parts that go into the patient. Okay, so here we have our injectable medications. Parenteral drugs must be prepared, packaged, administered in ways to protect and maintain sterility, right? So we have vials or ampules. We have pre-filled syringes. They may come in a powdered form in a syringe. You're always going to check for expiration dates, right? And you're always going to look at the substance and make sure that it looks safe, right? It doesn't look expired, because sometimes we'll get IV fluids that'll be yellow, right? That are expired, normal saline, right? I'm not talking like TPN or the banana bags, right? That are purposeful yellow. I'm talking about fluids that turn bad, right? Over time. So you're going to check dates, and you're also going to check the look of the substance to see if it looks expired, right? So check the fluid for clarity and color. You're always going to wear gloves to administer. You're going to ensure that you do engage the safety device always on your needles, right? Needle guards. Never ever recap. I can't stress that enough. And you can see in that picture on the bottom right, that's how you recap a lot of the needles, right? Or the needles on the left, where you push the plastic piece over it once the injection is completed. Drugs that are administered by injections are packaged in several different ways. Those that deteriorate in solution are usually dispensed as powders, right? And then we have to reconstitute them immediately before injecting. Okay, again, the reason they come in powders is because if they were pre-mixed, they would deteriorate and therefore would be ineffective, right? Drugs that remain stable in solution are usually dispensed in ampules, bottles, pre-filled cartridges, maybe vials with aqueous or oily solutions or suspensions, right? But the bottom line is, if it's safe, they'll probably, prepare them ahead of time. Drugs may be dispensed in single-dose glass ampules. Again, if the solution deteriorates, if it's stored in plastic or some form, it may have to come in glass, right? Single-dose rubber-capped vials is another way that they can dispense it. Multi-dose rubber-capped vials, we see those a lot in the long-term care and skilled nursing facilities. Maybe pre-filled cartridges. When considering mixing two medications in one syringe, please first ensure that the two drugs are compatible, right? They must be compatible or they cannot be mixed in the same syringe, period. Certain medications, such as diazepam, are incompatible with other drugs in the same syringe. So you got to know these things before you mix them and then potentially harm your patient, right? Other drugs have limited capability and should be administered within 15 minutes of preparation, right? Incompatible drugs may become cloudy or form a precipitate in the syringe itself, right? So it's extremely important that you know exactly how to mix those meds, and your drug guides are going to tell you that, right? So you're going to rely heavily on them. Discard these medications and re-prepare the drugs if you prep them incorrectly to begin with. So waste them and start over. Mixing more than two drugs in one syringe is definitely not recommended. So let me repeat that. Mixing more than two drugs in one syringe is not recommended, even if all three drugs are compatible, for example, right? So if it must be done, you're going to have to work with the pharmacist to determine the capability of those three drugs, as well as the capability of their pH values, as well as the preservatives that are used in each presenting drug. Like, there are a lot of factors. So if you must mix three meds in one drug, you must do it with the guidance of the pharmacist themselves, okay? A drug capability table should be available to nurses who are preparing meds. We always have access to them in the drug guides. Insulin is administered subcutaneously. There are specific rules for mixing insulins, as some insulins are not compatible and must be mixed in a particular order. So please see the skill of mixing medications from two vials in one syringe. Okay, there is information on that in your book. And also look up the chapter for mixing medications in one syringe. Take a look at the book and the information also surrounding focusing on the older adult, as it describes age-related changes that can affect drug response in the body. It is important to understand these principles, as the older population is susceptible to adverse reaction and drug toxicities. Injections are given subcutaneously, intradermally, and intramuscularly, right? And subcutaneous injections are given in the subcutaneous tissue. We're going to avoid sites that are bruised. We're going to avoid sites that are tender, hard, swollen, inflamed, scarred, tattooed, all of that, right? Absorption rates differ among the various sites, and injections in the abdomen are absorbed more rapidly. Ones in the arms are absorbed somewhat more slowly than those in the thighs. And then the ones in the thighs are even more slowly, right? Those in the upper ventral or dorsal gluteal areas have the slowest absorption. And intradermal injections are administered right into the dermis, right, just below the epidermis. And the intradermal route has the longest absorption time of all the parenteral routes. For this reason, intradermal injections are used for sensitivity tests such as tuberculin, allergy tests, even some local anesthesia. Intramuscular injections deliver medication through the skin and subcutaneous tissues into certain muscles. Muscles have larger and a greater number of blood vessels than subcutaneous tissue, thus allowing faster onset of action than with subcutaneous injections. Some medications administered intramuscularly are formulated to have a longer duration of effect. The deposit of medication creates a depot at the site of injection designed to deliver slow, sustained release over hours, days, and even weeks in some instances with certain meds, right? And this route is used to administer drugs such as antibiotics and hormones or vaccines, such as, pneumococcal or hepatitis vaccines, right? Okay, so here we go. Number one, check the expiration date of the drug and note when it was opened. Remember, drugs can be kept for varying length of time if it's in a multi-dose vial. So whatever length of time, if it's 30 days, you're going to look and make sure it's within the expiration of that drug. If it's 24 hours, same thing, right? Number 2, you're going to swab the rubber top with an alcohol wipe, and it's going to include friction, and you're going to do that for a minimum of 20 seconds. Number 3, you're going to add air to the vial, right? So the same amount of volume as the medication dose that you're giving. So this will prevent the vacuum inside the vial from forming, okay? So again, you're going to replace, this is called the displacement factor. So if you're pulling out 2 milliliters, you're going to add 2 milliliters of air into the vial when you go to pull the med out, right? So you're literally replacing the amount of volume you're pulling out. You're going to invert the vial, just like it shows in the picture. Pull back on the syringe plunger and draw up the med, keeping the vial at eye level. Number 5, after removing the needle from the vial, you're going to tap the barrel very lightly of the syringe to remove any excess air bubbles, right? Number 6, if this is a newly opened vial and it's a multi-vial dose, you're going to label the vial, date and time the vial, and you're going to put your initials on there, right? So that it's labeled for the next nurse. Okay, so here's an ampule. Again, we have them in our blue bags. It's a sealed glass container with the medication inside it. Again, the tops must be broken to allow insertion of a special needle that will draw up the med without drawing up glass in it as well, right? So safety concerns, clearly having glass in the medication that you're going to put in your patient, right? That's why you have to use a filter needle to draw up the meds out of these ampules. So you're going to pop off the top. Again, we're going to walk you through this in class in week 6. And you're going to put on a filter needle to draw up the medication from the ampule itself. And then it's extremely important that you change out that filter needle and not inject that med into, with that filter needle. So you got to switch out the filter needle after drawing up the med, put on the injection needle, and then you can inject it into your patient, right? So again, with your glass vial in hand, you're going to tap the top of the glass vial to get any medication down that might be stuck in the top. You're going to put the plastic piece over the glass ampule part. You're going to literally pop it off, and you'll see that the glass part will end up in the plastic piece that will have the medication in there. You're going to put the filter needle onto your syringe, just like it does in the picture on the left bottom. You're going to draw up the medication using the filter needle. That ensures that the medication doesn't have any glass in it. You're then going to twist off that filter needle and replace it with the actual injection needle, which you can notice in the picture on the right bottom, totally different needle. Here is pre-filled syringes, right? So there's 2 different types there that you can see. They're single dose, and then you must have the needle, you must attach the needle, right? And then at the bottom there we have Tubex and Carpojet, different types of brands of pre-filled injections types. Drug classes refer to groups of drugs that share similar characteristics. 2 primary classifications are pharmaceutical class and therapeutic class. Pharmaceutical class refers to the mechanism of action, the physiologic effect, as well as its chemical structure. The therapeutic class refers to the clinical indication or therapeutic action. So, for example, analgesic, antibiotic, anti-hypersensitive, etc. Learning the drugs by classes can help to understand the individual drugs in that class. Learning the drug classes and grouping them into classes does help you to remember what the indications for each drugs are, right? As nurses, we are responsible to understand the method of action of the drugs we are administering. How else do you know if the patient received the desired effect in your evaluation? Also, it is our primary responsibility as a bedside nurse to teach our patients about their medications, the proper use, their side effects, their adverse effects, the desired effects, and so on. As a reminder, therapeutic levels of drugs are important. Examples are antibiotics. Some antibiotics have what we call a loading dose. So this means that we got to give a bigger dose up front, right? So this will potentiate that therapeutic effect. And then the subsequent doses will just maintain that therapy over time, right? Sometimes we'll have a trough level for certain medications. Those are taken for drugs that to ensure that we're in that therapeutic range, right? That therapeutic level. And we also monitor for toxicity, right? Trough levels are identified with blood tests, and they give the pharmacist an idea of how to change the dose to maintain therapeutic levels and to keep that patient from reaching any kind of toxic level, right? Half-life of medications are important to understand as they have to do with the elimination of drugs from the body, right? And remembering patients that have elimination issues like kidney or liver problems or even slow gastric emptying, that's going to extend the half-life, right? It's going to affect the half-life of their meds. A longer needle is required for an intramuscular injection than for an intradermal or subcutaneous injection, right? Because you got to go further in to get to that muscle. Some medications are more viscous than others, right? Some are thicker and require thus a larger lumen to inject that drug, right? Larger lumen. So thicker meds will need a larger lumen. The larger the amount of the medication to be injected, the larger the syringe needs to be. Smaller syringes should be used as needed for precise dosing because they provide smaller increments of measurement, right? And we never ever want to estimate a dose. So again, if you have a really small dose, then you want to get a smaller syringe because they're more precise. An obese person requires a longer needle to reach muscle tissue than a thin person, right? Because you got to go through more subcutaneous tissue. A thin person or an older person with decreased muscle mass requires a shorter needle. That's why you'll see many times when we're doing different types of injections, it'll give us a range of needle size because as a nurse, you have to make what's the best needle size within that range, right? And there are special syringes for certain types of uses too. For an example, the insulin syringes are specifically for administering insulin, and you must have an insulin syringe when administering insulin. Okay, so you're going to assess your client for the appropriate size of needle, length, size, and all of that, right? So is the patient obese? Are they thin? Do they have little to no subcutaneous tissue? Not no, but little subcutaneous tissue and all of those things. You do need to be able to quantify based on the type of injection what the needle gauge will be as well as the needle length. So please get this into your permanent long-term memory, okay? Subcutaneous drugs, again, we're going to be doing anything from insulin injections to heparin, those kinds of things, right? And you want to make sure there are certain rules, like you never give more than 1 milliliter of an injection at that site, right? And you want to use the angle that ensures infusion into the subcutaneous tissue, not muscle tissue. So make sure you're using the right size needle, right? And again, you never want to aspirate, right? You got to definitely rotate sides because if you don't rotate sides, you'll get scar tissue, which isn't good, right? So rotate sides, avoid overuse of those sites and damaging that tissue. And again, I cannot stress this enough. Insulin has to be drawn up with an insulin syringe, right? You cannot draw it up in any other type of syringe because it's in units, right? Which is its own type of unit, and therefore you can't cross over to mils ever. Okay, so when we're doing intradermal, right, we're doing blebs. We're putting it right right under the epidermis and right on top of the dermis, right? And we're getting in there so that we can do that 10 to 15 degree angle and get that good bleb in there, right? And again, we're doing these types for TB tests, or allergy testing is typically intradermal. Then we have our subcutaneous, right? Shows you the angle of that, 45 to 90 degrees, depending upon how much fat tissue is literally in your patient's body, right? You may even, if you have an elderly patient who's really thin and doesn't have a lot of subcutaneous tissue, you may have to go at a sharper angle even more than 45. And then intramuscular is typically 90 degree angle right into the skin, like a dart. Okay, here's a picture, the various sites that may be used for subcutaneous injections, including the outer aspect of the upper arm, the abdomen, from below the costal margin to the iliac crest. You can use the anterior aspects of the thigh. You can use the upper back, the upper ventral area, the upper dorsal gluteal area. There's like a lot of spots, okay? So if you can't find subcutaneous tissue on your patient, readily available in their abdomen, then you can look at these other areas, right? This is an example of a subcutaneous injection into the fatty tissue at the back of the arm. Intramuscular injections are given in 3 muscle groups. The first is the ventral gluteal site. This is the preferred site for adults, as it is a large muscle mass, and it has less nerves and blood vessels near the site. So you put the patient in a side-lying position with their knees slightly bent, and then you find the head of the greater trochanter, place your palm over the head and point your thumb towards the groin and your index and middle fingers toward the anterior iliac spine. And then you want to spread your index and middle finger, and then you will literally find your spot. Okay, we're going to practice this in class as well. Hand positions may vary depending on the size of your hand and the length of your fingers, right? The ventral gluteal site takes a 1 to 1.5 needle size, depending upon the size of your patient, right? And if they are obese, you can definitely use up to a 2-inch needle if needed. Next site is the vastus lateralis muscle in the leg. This site also does not have any large nerves in the area. It can take a needle 5/8 inch to 1 inch long. Again, we're going to teach you an easy way to find this injection site in the classroom and lab. This is also the preferred site for babies and children. Both the ventral gluteal and vastus lateralis muscles can take up to 3 to 4 milliliters of solution in those injection sites. The next site is the deltoid muscle, and we usually use this site for all vaccinations, right? For most, I should say, vaccinations. There is possible damage to the radial nerve as well as the radial artery, so you just got to be careful, right? Make sure you go high enough. No more than one milliliter can be injected in this site due to the size of the muscle. So don't ever do more than 1 ml of a fluid solution in that site. And deltoid injections usually have about a 1-inch needle. You definitely don't want to use this site for pain medication administration, okay? And I think it's really important that we mention that the dorsogluteal site is no longer recommended due to the possible injury to the sciatic nerve, okay? So we're not even going to teach you that site. Again, if you see it on a test, HESI, the dorsogluteal site is no longer recommended due to possibly injuring the sciatic nerve. Intramuscular sites are listed here. Again, we're going to be showing you these sites and landmarks in lab as well as in class, and we're going to practice doing injections into injection pads. See the book for the depiction of the sites and also for intramuscular injection needle length. You need to know those, right? I've mentioned that. So make sure you know them and you will be tested on that information. And you need to be able to know it right offhand as a nurse, right? The volume of medication that can be administered intramuscularly varies based on the intended site, right? And we just mentioned a lot of those, right? But in general, 1 to 5 mLs is the accepted volume range, right? And the smaller muscles obviously will have much less fluid in them, right? That's why the deltoid is no more than 1 ml. And then, of course, children, they have less developed muscles, right? So we're going to limit their overall injections to 1 to 2 mLs. While administering an intramuscular injection, you must perform the Z-track technique. This slightly pulls the skin and subcutaneous tissue to the side as you inject the medication. When you release the tissues, it slides back over the injection site to help prevent the medication tracking back outside where you poke the patient, right? Again, we're gonna go over this in lab and class, so we'll practice this. And then the next injection type is IV administration. We're not going to be doing that. That's in block 2. So when you come to that reading material in your book, you'll want to skip it. Okay, so here is the ventral gluteal site, right, which is our preferred site. And again, you're going to take the opposite hand. So this is the right side of the patient. So literally what you're going to do is you're going to take the left palm and you're going to place it over that greater trochanter. So you're going to put your left palm over that. You're going to put your thumb toward the groin and your middle finger and your pointer up, spread out, and you're going to place the injection between your pointer and your middle finger, right where this diamond is at. Okay? Again, we'll practice this in lab and class. Now this is the opposite. This is the patient's left side. So we're going to take our right hand and do that exact same thing again, right? Thumb toward the groin and then the other finger spread out, and you're going to do the injection there. So here it is, literally on a patient lying in bed, right? So again, the top left picture is the patient's left hip. So you're going to put your right hand over that greater trochanter, spread your pointer and middle fingers out, and your injection spot is literally right there between the two. See how high up it is? All right. Here is a picture of the deltoid muscle and the deltoid site, right? So your injection is literally 3 fingers from, or 4 fingers from, what we call the acromion process. That's the top where the clavicle meets your acromion process. So you're going to literally put your little finger up against that acromion process, and then that's going to show you exactly where you need to inject in, right, into that deltoid muscle. This is, again, perfect, right? Put your 4 fingers up there, and that's the injection spot. And here's the vastus lateralis. So literally your injection site or your landmarks, right? You're going to find your greater trochanter of your femur as well as your knee, the top of your patella, right? And then you're going to put both of your hands, your 4 fingers from both hands at the top where the greater trochanter is at. And then you're going to put your other 4 fingers toward the bottom there where your patella, right by up at the top of the patella. And then your injection, your vastus lateralis injection site's going to be in between that, right? And we'll show you a really easy way to mark your landmarks in class, okay? So again, we're going to the outer aspects of the leg, right? And so you're going to do the vastus lateralis muscle, not the rectus formis muscle, okay? And here's the dorsal gluteal site we no longer use, okay? It's the one right above the buttocks, okay? And it's because the sciatic nerve literally runs right by where we used to do that injection site. Okay, so intradermal drugs, right? So again, we want you to see the skill for the instructions on administering intradermal injections, right? And the skill is located in your book, and we're also going to be this is one of your checkoffs, so we'll be doing this in lab. We're definitely going to be going over the skill in lab and in class. Your medication will be administered into the dermis, right, just below the epidermis. And it does have the longest absorption time of all the parenteral routes. We use this site for sensitivity testing and sometimes for local anesthesia. Body's reactions to the substances is easily visible, and that's why we use them, right, for allergy testing or testing to see if you've been exposed to TB. Sites commonly used are the inner surface of the forearm or the upper back or the upper scapula, right? And 1/4 of an inch to 1/2 of an inch is usually used, and a 25 or 27 gauge needle is typically used. The angle of administration is 5 to 15 degrees, depending upon the patient. And the dosage given intradermally is very small, usually less than 1/2 ml, okay? Okay, so here's the technique. Remember, bevel up, right? And you're going to go 5 to 15 degrees, and you're going to literally advance your needle into this under the skin there, right? And literally with the bevel up, you're going to push it in a little bit further, and then you're going to literally form your bleb by pushing the medication or your wheel, pushing your medication under the skin. So you're going to literally get this nice little bubble here that will mark the location. Intradermal sites could be on the upper chest here, right? Anteriorly or posteriorly over the scapula. Many allergy testing will do it on the right by the scapula. And then of course on the lower arm here, right? For TB tests as well as allergy testing I've seen done there as well. Reconstitution of medications. So the diluent is the liquid used to reconstitute a powder drug and change it into a liquid form, right? So we usually use the diluents, our sterile water, we might have normal saline, we might have bacteriostatic water, we could have lidocaine, right? So if there's a real viscous solution that burns, we'll use lidocaine to dilute it, right? So it doesn't hurt as much, although it, like Rocephin, for example, it burns. And so we'll dilute it with lidocaine. It still burns, but at least it's better than if you just put it in by itself. So after adding the diluent, the amount of drug is increased because the powder drug occupies space, right? So for example, you may add 2.6 mils of diluent, but you only have a drug yield of 3 mLs in liquid form, okay? That's called the displacement factor, okay? So again, the powder and the solution will add volume to the solution, so it increases the total volume of the mixture. For example, if we add 5.6 mLs of sterile water to the powder, the total volume that you're going to be, admitting to the patient after reconstitution would be 6 mLs, okay? Again, that's called the displacement factor. Again, remember, you want to note the length of time the medication is good for once it's reconstituted, and ensure that you inject it within that time frame, right? Again, you want to make sure that you follow all the directions for storing your medications once mixed. Put the date, time, and initial the vial once it's opened, and then of course it's only going to be good for however long that medication is stable for. Make sure we're always checking for expiration dates, and then we're going to be practicing this quite a bit in lab and in class. All right, next is heparin and insulin. Here are learning objectives for this piece of it. Insulin administration is done using very specific syringes for insulin. They are measured utilizing units, And it is done with U100 or U500 syringes, right? So U100 has 100 units per 1 ml, and U500 has 500 units per 1 ml. So you want to make sure you're grabbing the right syringes. And you're only going to give them subcutaneously or IV. And IV is only going to be for regular insulin only, okay? Again, I cannot stress this enough. You are only going to use the orange tip syringes for insulin. They are specifically for insulin. That's it, right? And again, we're never going to aspirate at the site or massage the site. You don't do either one of those. You don't aspirate and you don't massage once you do the injection. Again, we have syringes that have 30 units. We have a 50 unit syringe, 100 unit syringe. We just talked about the 500 unit syringe. We do have insulin pens that come out with different volumes. So you'll see a bunch of different types, right? Okay, so we have rapid acting insulin. We have short acting. We have intermediate acting, and we have long acting, okay? So again, rapid acting or Lispro, short acting or regular insulin, right, which is the one you can give IV. Intermediate acting, which is NPH, and then long acting, which is Lantus, okay? Then we also have pre-mixed solutions, which are intermediate and short acting mixtures. So that's a 70-30 or 50-50 solution. And while the slide says you don't need to know the different types of insulins at this point, you will need to know them for your exam. So start learning them now, right? You are going to acquire this information when we do diabetes. So right now, all you really need to learn is all about the insulin, syringes and types and things like that, right? But as far as memorizing the different types of insulins and when you would give them, that comes with diabetes in a couple weeks, okay? But please know the syringe types, the safety implications when we administer them, the needle size, the barrel size, all of that stuff. So in a typical insulin order, your doctor's going to tell you the name of the insulin, type of insulin, the number of units you're going to be given over a specific time frame, and the route to be given. You want to definitely read the orders thoroughly. You want to definitely make sure you're using only an insulin syringe. You're going to read the labels extremely careful. Regular insulin is clear and should always be drawn up first if mixing with intermediate acting insulin, okay? And you want to always do a second check with another RN because insulin can kill your patient if you have the wrong dose. So it's a high risk medication, and therefore most facilities will have you do a double nurse check, and you definitely need to in nursing school. Well, in block 1 you don't hand out meds unless your instructor's with you anyway, but I will say that if you're doing any kind of meds, you want to make sure you're double checking with the nurse if it's a high risk med like insulin, right? Again, when you're mixing insulins, we can do Lispro, should be drawn up first. You're going to, again, draw up clear before cloudy. So you're going to draw up Lispro first, then the NPH. You're going to draw up exactly as it's ordered. And we do sometimes have what's called a sliding scale insulin. And this is to cover a patient's increased blood sugars due to maybe diet or stress and stuff like that, right? So this is a sliding scale, and most of the sliding scales are the same. They match. And your facility will have a sliding scale that they use. Okay, heparin. Again, heparin administered, it's supplied in units as well. It is not given using an insulin syringe, but you need to use the heparin, you need to use the heparin unit syringes, okay? It is given either IV or subcutaneously in the abdomen, and again, you need to make sure you're using a unit syringe because heparin is given in units. There are various strengths available, just like with most meds. We have fast acting, shorter half-life medications. The antidote, which you should always know, is protamine sulfate. We do some heparin doses based on labs, so we'll get a PTT. We need to know that with heparin, it is incompatible with other medications, so just make sure you know that it's compatible, and you do not interrupt or delay administration of this medication. Remember, we're giving it because they're at risk for blood clots, right? Okay. So, again, heparin, short, small, subcutaneous needles, right? And then if you need to change the needle, you can to avoid bruising, but just remember, we do not exceed 1 ml in subcutaneous tissue, right? Inject in the left or right, anterior or lateral, posterior, lateral, abdominal area, picture right there. We're gonna, before administering, we're gonna double check the order. We're gonna make sure the dose is accurate. We're gonna make sure the amount. We're gonna have another RN check it, right? We're gonna use a TB syringe, right? The ml side. Only use a TB syringe if a heparin syringe is not available. Remember, don't use an insulin syringe though. So TB syringe if a heparin syringe is not available. Know your symptoms of an overdose and do not, again, massage the area once injected or aspirate, okay? Medical record documentation. So documentation of injections are listed on this slide. So in addition to site location, you will also note if the patient tolerated the injection or not, right? And so you're going to name the medication, the dosage, the route, and time of administration. You're going to sign it. You're going to literally note the site that you used for the injection. So deltoid muscle, left, you know, you're going to list any kind of reactions from the patient. Explaining the techniques of medication administration to the patient and family is important, right? Before being discharged from a healthcare facility, the patient should practice the necessary techniques under the supervision of a nurse to make sure that they have acquired the sufficient skill for safe med administration, right? And so teach one, show one, do one, right? So that's probably the best method for patients, right? Have them teach you, have them show you, right? Pretend like they're teaching you how to do it. That's the best way. Many patients have learned to give themselves injections as well as many other medications. So when the teaching, planning, so patients will be able to learn. So when you go to do your teaching with your patients, make sure it's a good time for the teaching, right? Because the worst thing you could do is try to teach them when you know, they're upset or something else is going on. So just make sure it's a good time. You want to emphasize the importance of taking medications as prescribed and for as long as prescribed. A common error made by patients is simply omitting a drug, either through carelessness or because they truly believe that missing a dose isn't important, right? So we have to make sure they understand the importance of not skipping doses or stopping before, you know, the therapeutic, all of the med is taken, basically. Instruct the patient not to alter the dosing without consulting the primary care provider, right? Or the provider who ordered it. Also teach the patient not to discontinue meds when symptoms disappear. That's not good, right? They need to take the full course of the meds. Drugs used to maintain health, such as those used to control high blood pressure, high blood sugar, all of those, right, need to be continued as ordered to avoid reoccurrence of symptoms or worsening symptoms, truly, right? Because if you're on hypertensive meds and you stop those abruptly, you could actually get what's called rebound hypertension, which is hypertension that comes on with a vengeance, and it can be almost impossible to regulate at times. So it's very, very important patients not stop taking meds that they're taking just sporadically, right? They got to have conversations with their doctors before they do that. And then you want to always throw your needles in the sharps container. I cannot stress this enough to you. Your safety is of utmost importance. So immediately after injecting the solution, you're going to put your needle in the sharps container. Don't worry about your patient. The little amount of blood that's going to be there will still be there once your needle is safely discarded. So discard your needle first, then go to your patient and do what's needed there. Okay, this is the end of the chapter.